Hello, this is Lieutenant George Clevenger, student physical therapist with the United States Army Baylor Doctorate of Physical Therapy program, student intern, Texas Physical Therapy Specialist, Selma Clinic. It is a case study for 10 September 2011. Patient is a 45-year-old female. This is a mother. Exercise includes walking approximately 1 hour a day. Her mechanism of injury is both an insidious onset and a sudden injury. P1 is a constant variable heavy ache, 3 to 8 out of 10. Aggravating factors include any weight-bearing activity, which immediately increase her pain. Easing factors are rest, which immediately decrease her pain. At times, patient reports that pain decreases with increased activity. P2 is a constant variable heavy ache, 2 to 8 out of 10. Ag and ease factors are same as P1. P3 is a constant variable shocking, shooting, stabbing pain, 4 to 9 out of 10, with numbness and tingling. Aggravating factors are wearing heels, easing factors are rest. P4 is a constant variable central low back pain. Agonies will be assessed more in the next visit. P1, as P1 increases, P2 also increases. P1 is always greater than P2. Rest makes her symptoms better. Walking and standing make her symptoms worse. Her symptoms are always best in the morning and worst at the end of the day. Other aggravating factors include walking, standing, and exercise. Previous surgical history include tonsils in 1981. She is not currently taking any medication for her symptoms. She has had x-rays and MRIs. The x-rays in April showed no significant pathology. The MRI in May showed a large bone contusion of the tibial plateau. The MRI report indicated a fracture, but she was told by her doctor that it was a bone contusion, severe contusion. MRI also indicated a tear of the posterior horn to both medial and lateral menisci. Her photo scores, as you can see, they are below average, and her fear score is fairly high. Her symptoms are right knee and left foot. Started approximately November 2010, both gradual and injury. November 2010, a patient reported after starting Zumba classes that posterior P2 pain. She also reports increased activity of wearing heels, walking more than an hour a day. In April 2011, when she was at Six Flags, she turned to talk to her patient, left her foot planted. As she turned, she heard a crunch and noticed some slight swelling. She stayed and enjoyed the park for approximately 4 hours. After that, the pain increased to a point where she could not stand it, and she reported to the ER. She has received treatment for this problem. She does not have this problem before. The treatment for this problem was non-weight bearing for 8 weeks, as she was told by her doctor. It was a severe bone bruise. Her goal is to regain 100% use of her knees without increase in pain, and she does not have learning barriers. Past medical history, the only thing significant would be osteoarthritis and cancer. The cancer is a family history on her father's side. Father had prostate cancer, and a few of her aunts had breast cancer. Patient told by her doctor she also has osteoarthritis in both hips. And she does also have numbness and tingling. That is P3. Primary competing hypotheses are P1 is the meniscal tear, P3 nerve entrapment, P4 mechanical low back pain. Stability category, also there is a possibility of it being directional preference. Competing hypothesis could be an MCL tear, ACL, PCL tear, or lumbar radiculopathy. In the objective examination, going through the lumbar spine, at rest, P4 was 0 out of 10. The pain was reported with all active range of motion. Flexion 80 degrees, increased P4. Extension 15 degrees, increased P4. Side lying 15, increased P4. Side bending to the right, when 30 degrees, it actually did not increase P4. Overpressure is reported as more painful. Observations, she had an antalgic gait with a lateral shift to the left side and increased lumbar lordosis. prone PAs caused P4 at L4 and L5. There's also positive sacral spring test. Unable to clear the hips. Range of motion was within normal limits, but P4 increase was scour in favor. Knee range of motion was within normal limits. Flexion with medial rotation increased P1. Negative anterior and posterior drawer. Negative varus and valgus at 0 and 30 degrees. Negative Lockmans. Positive McMurray's for medial meniscus. Ankle and foot. All range of motion is full and overpressure is unremarkable. Slight numbness and tingling on the plantar surface of the left foot near the metatarsal phalangeal joint that did not follow dermatomal or peripheral nerve patterns. DTR, mild terms, dermal terms are unremarkable. The upper motor neuron tests were clear. She did have general bilateral weakness of hip flexors, knee extensors, and knee flexors left greater than right. Our primary hypothesis was a meniscal tear with a positive McMurray's, pain with medial rotation of the tibia during flexion. We're ruling that in. Competing hypothesis was MCL sprain, negative varus valgus at both 0 and 30. PCL, ACL sprain, negative anterior drawer, negative Lockmans or 1A Lockmans. Lumbar radiculopathy. Patient did not exhibit diminished dermatomal sensation or myotomal weakness consistent with radiculopathy. Conclusion, meniscal tear. Plan is to strengthen musculature around the knee, proprioceptive exercises, and neuromuscular re-education. Treatment of the same day, we did heel slides 3 times 10 to maintain range of motion after the 8 weeks of non-weight bearing, and for hamstring activation. We did quad sets, again to maintain the range of motion, and for quad activation. We did straight leg raise in flexion to strengthen hip flexors and knee extensors. We did not retest impairments at the end of today's treatment. HEP was the same as the Therex, heel slides, quad sets, and straight leg raises. On a follow-up visit, patient reported that her low back pain has increased with the last visit and stayed elevated for 2 days. Patient also reported she went shopping with her daughter and was walking for greater than 2 hours. When asked when pain increased, she said about 45 minutes, but she continued to walk on it anyway. Right now, she feels her pains are probably about, knee pain is 3 out of 10. Her low back pain is 6 to 7 out of 10. She has not felt P3 since she stopped wearing heels. Did not measure an asterisk at the start of the visit. During the course of the visit, noticed that prone knee flexion increased P4. HEP patient was compliant, or reports being compliant, until her back pain got too high and she just rested to help decrease that pain. And that's why we took the treatment on treatment 2 more towards the back so we can get more compliance for knee exercises. So we started with cardiovascular exercises and then went with lumbar stabilization exercises, 1, 2, and 3. Prone knee flexion with the strap, which actually increased P4. A double knee and single knee to chest, and then a psoas stretch in a Thomas position. Applied manual therapy, did a sideline neutral lumbopelvic gapping mobilizations in grade 3 and grade 4, but that increased her low back pain. Also did PNF, psoas stretch, which actually decreased the low back pain to 0 out of 10. After treatment, patient could perform the prone knee flexion without increase in low back pain. Low back pain did increase with a neutral gapping. Mobilizations had the patient perform psoas or Thomas stretch, and pain decreased to 0 out of 10. Added lumbar stabilization 1, 2, 3 to HEP, PNF stretch, and prone knee flexion. The plan is to continue with the plan of care. Add lower extremity stretching and proprioceptive training at the next visit. Next visit, patient reported she was feeling great after last visit. She has taken it easy and has not added activity. Her right knee is now 0 out of 10. Her low back is 0 out of 10. She reports walking waking up with a kink in the right side of her neck. A asterisk single leg stance was 10 seconds before she had to use support. Right cervical rotation approximately 60 degrees and cervical extension approximately 45 degrees before increase in that right side neck pain. She has been compliant with her home exercise program. Treatment for today is cardiovascular conditioning, lumbar stabilization, prone knee flexion, double single knee to chest, psoas stretch. We added a three-way straight leg raise, added the shuttle, both single leg and double leg, single leg stance, and clams. Manual did PNF, psoas again. Also added the CT and mid-thoracic manipulations with no cavitations. Post-treatment, patient could perform single leg stance 30 seconds bilateral on the last set of single leg stance Therex. Cervical range of motion was full and without increase in symptoms, and patient has excellent control for TRA. HEP added the single leg stance, a three-way straight leg raise, and clams. Plans to progress lumbar stabilization next visit. I'll follow up in 2 days for 5 Qs to assess dosing. Expect to see some symptoms, some symptoms to return. Continue graded exposure to muscle strengthening exercises and proprioceptive exercises.